All right. Thank you everyone for inviting me to join you today. My name is Hannah Green and I'm the National Director for Health Policy at the American Lung Association, and really hope that my presentation today can help us all to better understand some of the quality metrics that are important to lung health, especially those around asthma and tobacco cessation, and some of the key considerations, challenges, opportunities, impacts, other lessons learned that we can take from those metrics that can inform our conversation about quality metrics generally today, as well as our conversation about developing a metric specifically around lung cancer screening. So first, why are we talking about quality metrics? I really see quality metrics as an important tool to drive improvements in access to guidelines-based care, whether that be asthma care, tobacco cessation treatment, or other key benefits for patients with lung disease. And this can be driving improvements in coverage of services that are not uniformly covered by different payers, of services that are currently covered, but that have fairly low uptake, which is, more of the situation that we're in for lung cancer screening. So I'll talk a little bit more about that later in the presentation as well. Just to level set, I want to talk and briefly introduce you to two of the measures that I'll be referring to as examples throughout the presentation today. The first is the asthma medication ratio. Now, this is a HEDIS measure developed by NCQA, who I know we're also hearing from in today's panel, which assesses adults and children ages 5 to 64 who are identified as having asthma and have a ratio of controller medications to total asthma medications of 0.5 or greater during the measurement year. And that basically means that when you look at the medications that a patient is taking for their asthma, are the everyday maintenance medications that taking regularly is often helpful with good asthma control. Are those medications the majority of the medications that a patient is taking, or are patients relying often on emergency relief medications, suggesting again that maybe their asthma is not being particularly well controlled? The second metric I want to introduce is around tobacco cessation. This is medical assistance with smoking and tobacco use cessation metric. Again, this is developed by NCQA. Unlike the previous metric, it relies on survey data, and we'll talk a little bit more about that later as well. But the three kind of key questions that we're looking at here are, for adults over 18, have you received cessation advice during the previous year? Have you discussed or been recommended cessation medications? And have you discussed or been provided cessation methods or strategies, again, during the measurement year? So when we're thinking about quality metrics, I want to start by thinking about who are the payers that we're trying to influence. Who are the payers that are covering the patients that we want to see improvements in care for? So for a metric for lung cancer screening, we know we would want to have a metric that influence change in the commercial market, in Medicare, and in Medicaid, based on the patient population that's eligible for screening. I will also just stress that given the USPSTF recommendation that was released this summer, if finalized, would decrease the age of eligibility for screening to 50 years of age. And so a lot of the newly eligible for screening would be covered by the commercial market and by Medicaid. And so I think it's really important that we think about metrics that could, again, really focus on and be utilized by those payers in particular. Luckily, the NCQA HEDIS metrics that we've been speaking about are dominantly used by all three of those payers. That's certainly a great starting point for us to be having this discussion. I also want to talk about Medicaid coverage in particular, which is a program that is particularly important for the American Lung Association, especially because patients with lung disease are disproportionately covered by that program. And a big part of that is because Medicaid enrollees smoke at a rate over twice as high as those with private health insurance. And so again, given the reliance on tobacco use history and the eligibility for lung cancer screening, that's going to be a sign that Medicaid, it will have a number of enrollees who will be eligible for screening, and we want to make sure are getting screened. So if you're not familiar with quality metrics in the Medicaid space, there are two key sets of metrics that we really track: the child core set metrics and the adult core set metrics. These are currently voluntary metrics, although the child's core set and the behavioral health metrics in the adult core set will start being mandatory in 2024. They currently include both the asthma and tobacco measures that I spoke about on the previous slides in the adult core set, and a version of the AMR, the asthma metric, is also in the child core set as well. So looking at the adult core set, which is probably of more importance for the conversation we're having today around lung cancer screening, while the measures are voluntary, there are currently 33 measures in that set that are reported by Medicaid programs. 40 states report more than half of those measures, and the median number of measures reported, this is for calendar year 2018, was 22.5. So even though they're voluntary, there is fairly good reporting of these measures, and I think that they're thinking about a measure that could be included in the adult core set is really important as we think about a measure that could influence change and improve care for this particularly important population. So turning to some of the challenges and opportunities that we've seen with our experience in asthma and tobacco cessation metrics, I want to start by talking about the challenges in measuring exactly what you want to measure. And certainly starting with asthma, medication usage is not a perfect measure of asthma control by any means. And I have been part of multiple conversations over the past couple of years about how can we get a metric that is more comprehensive, that incorporates more data, that is a better measure of asthma control for patients. And often those conversations, end up getting sort of bogged down in questions about, well, if you want something else, where are we going to get that data? How practical is that? Is it, uniformly collected by providers? Can we get it from claims data? And so I think a lot of those challenges are challenges that we also may face in talking about the development of other new metrics. But I also want to say that even a metric that has its limitations can still be impactful, and I'll talk about that more in a minute. The other big challenge that we see is around tobacco use information, which of course will be directly relevant to the conversation about a lung cancer screening metric. First of all, when I talked earlier about the metric that we have for cessation relies on survey data, which introduces some potential biases. We know that smoking history is something that is often underreported by patients. There have also been issues with sample size in certain cases, and so we know there are some limits to using survey data to collect tobacco use information. On the flip side, when we talk about, again, developing a metric for lung cancer screening that would rely on, the tobacco use history to determine eligibility criteria, there are limits in other places we could get tobacco use information. Electronic health records, that information is often, recorded in different places and different systems, whether it be in specific fields or in the notes section. There can be challenges with recording change over time. So certainly there are questions about how are we measuring tobacco use that I think we'll certainly have to grapple with as part of this discussion. But, turning to more of the positive side, I certainly want to talk about impact as well. And as I mentioned earlier, really, I see quality metrics as being an important tool to drive improvements in both coverage and utilization of services. And we've already seen evidence of that starting to happen with the asthma metric that I spoke about earlier, even though, as I've acknowledged, it has its limitations. And so just to give an example from the Medicaid space, some of the services that we are interested in and have been tracking changes in coverage of over time at the Lung Association is asthma home visiting services. So these include both environmental assessments in the home, maybe self-management education in the home that can help patients better control their asthma, address triggers in the home, and learn how to better manage it. So we have seen these are services that are not often covered by state Medicaid programs, but we have seen over the past few years, state asthma programs and other stakeholders increasingly partnering with their Medicaid programs and saying, how can we share data? How can we look at a, say, pilot program that we've been running and say, this is the population, let's look at their data, their claims information before and after this intervention. Is there a change in the AMR? And if there is, that can really be helpful in building a business case building the evidence base for Medicaid managed care plans, Medicaid fee-for-service programs, other payers to show this intervention works. We need to improve access to it, increase coverage of it, increase investments in it. And so I really think that that's a great example of the kind of change that we can hope to see by finding a quality metric for lung cancer screening. And I will say, again, focusing on the Medicaid space, the Lung Association for the past couple of years has been tracking Medicaid coverage of lung cancer screening in fee-for-service programs. And we have found that there are still 9 states that don't cover screening for their traditional Medicaid population, a few states where we still don't have data available. And so certainly a quality metric could be an important incentive to improve coverage in the states where we still don't see it. But also we know that across the board in Medicaid and other payers, utilization rates are still alarmingly low. The American Lung Association State of Lung Cancer Report for 2019 found that nationally 4.2% of those eligible for screening had been screened. We'll release updated data as part of our State of Lung Cancer Report in November, but still there is certainly quite a lot of work to do to improve utilization rates of lung cancer screening. And so really hope that across all payers, a metric could be an important tool to incentivize investments in patient education, provider education, quality improvement programs, other interventions that could really help increase awareness and access to screening, even when it already is covered by payers. So I think with that, I will leave it there and thank you for your time, and I'm happy to answer any questions at the end of the panel.